Good afternoon. Let's get started. I know everybody is probably kind of tired because you had lunch and your bellies are full. I'm really excited to present today a session on rare genetic epilepsies and epilepsy surgery. We're often told that if your child has a genetic epilepsy, there is not a surgical treatment for them, but that's not the case. We have two fellowship-trained epilepsy surgeons here today who are also researchers in the space of genetic epilepsies. Dr. Westley Phillips joins us from Stanford, as well as the Phillips Genetics Epilepsy Lab. Did I say that right? And Dr. Jason Hauptman, who's the new chief at Phoenix Children's. Both of them will share their thoughts on surgery for genetic epilepsy. Welcome.
All right. So we'll talk a little bit about epilepsy and the genetic underpinnings or implications of gene mutations in epilepsy and the surgical treatment for that. It's something that is very important both in my clinical and research practices. But before, anytime I give a talk about epilepsy, I always bring it back to why we do this, why I do this, and it's for our patients, like many of you all and their families. And in the past 6 months, I just jotted down some quotes that I received from patients and their families, and while I'll let you all read them, the gist, as many of you know, is that epilepsy causes anxiety, fear, has severe neuropsychological consequences, and can really impact quality of life. The one thing that many of these sort of statements are common across the board, but the thing that I sometimes or often hear the most is that I wish we would have decided to proceed with surgery sooner. And so one of my goals in giving these talks is to sort of inform people about epilepsy surgery, to spread the word so that patients are getting timely pre-surgical evaluations. So epilepsy is common. You guys know that it impacts about 1% of children. Focal epilepsies are the most common type of epilepsy, and in children, they're often associated with malformations of cortical development. Now, we'll talk a little bit about malformations of cortical development as we go into the genetic cause of epilepsy, but I would just say that they are often linked. After failing 2 or more properly dosed medications, a patient is rendered drug resistant, and the chance of the next medication working is less than 5%. And so it's not uncommon for patients to come see me that have tried 10, 15 medications before having a surgical evaluation. And we know with studies that uncontrolled seizures can have devastating consequences, both from an academic, social perspective, developmental. There's a 0.5 to 1% chance of SUDEP that's compounded each year. And the average time from epilepsy diagnosis to surgical evaluation is almost 17 years. And there's one thing that we say throughout neurosurgery and neurology, and that's time is brain. And so seeing these numbers, again, 16 years, 17 years, is far too long. And so epilepsy surgery is not the last resort, whether there's a genetic cause or not. And I can't stress that enough. And then the other key point, and it sort of relates to this balloon of hope, is that surgical indications are expanding. And patients that may not have been deemed surgical candidates 10 years ago even are now getting and benefiting from surgery, many of those with genetic causes. So there'll be a lot of talks about what epilepsy surgery is. Just very quickly, I'll give you my flavor of what I think about epilepsy surgery, there's a destructive or resection/ablation, or disconnection, that's sequestering a part of the brain, or stimulation with neuromodulation or neurostimulation. And all of these are options for patients with genetic epilepsies or epilepsies that are associated with gene mutations. And we'll talk a little bit about the different varieties of those and how each one fits into which category. Epilepsy surgery is safe and effective. Seizure freedom rates can be as high as 60 to 80%, depending on, again, the type of epilepsy and the surgeries that's performed, with 50% of patients being able to come off their anti-seizure medications, and the mortality and morbidity rates of epilepsy surgery are quite low. In fact, it's debatable about if comparing the risk of SUDEP to the risk of epilepsy surgery, and we know time and time again from the data that epilepsy surgery should be seriously considered in cases of drug resistance. But how do we make epilepsy surgery useful or effective? And a lot of that is identifying the region or regions of the brain that are causing the epilepsy. And that is through a comprehensive pre-surgical evaluation. And at a comprehensive epilepsy surgery center, EEG and an old MRI is often not enough. And so when I talk to patients, I talk about this portion of the evaluation like a crime investigation. So we're using these different modalities as circumstantial evidence to try to implicate certain areas of the brain to target. And so we do things like EEG and MRI and other advanced testing measures to try to identify those regions that we want to target. And sometimes when we don't have enough information from these non-invasive tests, we do a stereo EEG where we implant electrodes or sensors into the brain, and that would be like putting a camera in a bank vault and waiting for the crime to happen so that we know exactly what we're targeting. And that really impacts our ability to treat epilepsy with surgery. And then I haven't read here genetic testing. And so genetic testing, again, plays a major role, but a genetic diagnosis does not exclude epilepsy surgery. So if there's one thing that I want to take away one thing from this talk, and it's this. And we'll talk a little bit about the advances that we have in identifying genetic alterations and how that plays into our overall treatment of epilepsy. So, new sequencing technologies, we call it next generation sequencing, have allowed us to discover previously undetected mutations. And so, in a simplified way, when we think about the old school way of doing sequencing, which was very slow and very expensive, it was like we had to add 1 + 1 + 1 + 1. Everything was in sequence. And so that took a long time, and it limited the amount of coverage and the amount that we could cover every aspect of the genome. Now, next generation sequencing is based on parallel processing. So you have multiple things going on at once. So that allows for a much wider coverage of the genes that we're looking at, but it also allows for duplication of those same regions. And that's important because all mutations don't occur at the same percentage in each cell. And so you may have some mutations that are only present in 3 out of 100 cells. And so if you're only sampling 5, you're likely going to miss those rare mutations that may have a significant impact. And so that's one of the major advances in our next generation sequencing techniques. The other important thing to think about when we're thinking about mutations is that when the mutation occurs and how it occurs is very important to what the overall impact is going to have on the body and certainly on the brain. And so we have sort of 2 flavors of mutations. There's the acquired mutations, or actually I'll start with the inherited mutations. So these are mutations that are passed on from parents to children. Okay, these are called germline mutations. And then there are acquired mutations, which are mutations that occur in development. So you didn't receive them from your parents, but somewhere along the way, this genetic alteration occurred. And so the key difference between a germline and a somatic mutation is that a somatic mutation typically only impacts a certain tissue type. And so for epilepsy, we're thinking about mutations that occur in the brain. And so when a somatic mutation occurs in the brain, you're not going to find it in a blood test. Okay? And so that's sort of an important distinction, that when we're looking at blood tests, those are only telling you about the germline mutations that were inherited. And so to go on that, identifying genetic causes of epilepsy extend well beyond the blood test. About an estimated 70% of epilepsies are linked to one genetic cause or the other. Blood-based tests like the Invitae panel typically look at common mutations that are associated with epilepsy, and they target that in the blood. So again, these are looking for germline mutations that are occurring in blood. But an estimated 30% of patients, and especially those in children, are implicated with somatic mutations. And this requires access to brain tissue to detect. And the type of mutation, germline versus somatic, and that mutation's impact dictate the surgical outcome, surgical options, and the surgical outcomes. And we'll talk a little bit about that. And so, switching gears a little bit to the somatic mutations, because of our access to next generation sequencing techniques and our access to brain tissue from patients with epilepsy, we've identified that they are like a spectrum or continuum of disease, where many of these gene mutations are the same, but depending on when they occur in development, determine how much of the brain is involved. And so in this picture, there's a bunch of MRI scans that you don't need to worry about. You just trust me when I explain to you the key parts. And that is, when we look at a patient that has a focal cortical dysplasia, which is a common malformation of cortical development that cause epilepsy, if we look at that tissue, patients oftentimes have mutations that only occur in the brain. And those mutations are often in the mTOR pathway, which is an important signaling pathway in the development of the brain. And then if we look at a patient with hemimegalencephaly, where the entire hemisphere is involved, we also oftentimes find mTOR pathway mutations. And the difference is that the mTOR pathway mutation occurred earlier in development. And so instead of a very small percentage of the brain having those mutations, half of the brain had those mutations. And like focal cortical dysplasia and hemimegalencephaly, surgery is the option. And so my lab at Stanford looks at the molecular genetics of epilepsy, typically from surgically resected brain tissue specimen. So we look at the different data, including stereo EEG and EEG data, to determine what parts of the brain are implicated in seizures and what parts are quiet. And we take even electrodes that we implant into the brain, and we have been able to take brain that's actually attached to those electrodes, so you don't need a resection to actually test that brain. And we also take out different sections of what we would normally take out and study that individually. And what we found is that the percentage of mutated cells in leptogenic regions. And so this is a representation of the brain with some of the mutations sort of mapped on. And we found that these very bright red areas were the areas that we were causing the majority of the seizures, and the amount of mutated cells there was much higher. So we're hoping that over time we might be able to use sort of the genetics as a surgical plan where we're trying to achieve genetic margins in our resections. Dr. Hauptman, did you want to come and talk a little bit more about? Oh, that was a question.
I do
Yeah.
have a quick question. So this is kind of complicated, but I think I'm following. So from my understanding, 30% of non-inherited epilepsies, they require an extraction of tissue, is that correct, in order to diagnose? Is that what I'm getting from that?
So, in 30% of epilepsy that we know, and there's a little bit of a bias there because in order to find those mutations, we have to have access to the brain tissue.
Okay.
But in patients that have surgical resections that we then do genetic studies on, 30% of those patients have somatic mutations as the cause for their epilepsy.
Okay. All right.
Does that make sense?
Yes, it does.
You know, even to say something, thanks, Wes. Even to say something more provocative. So my name is Jason Hauptman. I'm at Phoenix. I'm at the Barrows Neurological Institute at Phoenix Children's, and you know, due to a lot of brilliant work, actually it goes back to our mentor Gary Mason, who's sitting in the audience there. I would say more provocatively that almost certainly all patients who undergo pediatric epilepsy surgery have a genetic issue. 100% of them. Okay? The challenge that we have is identifying exactly what that genetic issue is. Now, when we say genetic, you think back to high school, to that little chart that Gregor Mendel and plant genetics that you all had in high school biology of autosomal dominant and autosomal recessive and blue eyes, brown eyes, right? That is a very classic way of thinking about genetic issues. But as in life and as in medicine, things are way more complicated than we prefer them to be. And the things that we have to do to figure that out are nuanced. And as technology progresses, a lot of great work Wes has been doing that he showed you wouldn't have been possible 20 years ago, wouldn't have been cost prohibitive. I mean, sequencing, when I was in college, sequencing was something most labs couldn't even afford to do. It was like 20 grand for one sample, okay? And so as that technology progresses and miniaturizes and becomes more accessible, we're going to be able to answer these questions. But I'm going to say, and I've said it before.
Just to add on, sort of cap your point.
Yes.
The 30% they're talking about are estimates.
Uh-huh.
Because the technology does not allow us at present to figure out if there's a genetic problem in that brain unless you can sample it.
Unless you can access the testing.
And there is no institutional review board that's going to allow you to take a piece of someone's brain for the sole purposes of diagnostics. It's unethical.
And here's where it gets even trickier, okay? Here's where it gets even trickier.
Yes.
There's a thing in sequencing, that beautiful chart that Wes showed you, it's not an all or none phenomenon. It's how deep do you look? How hard do you have to look if only 5% of the cells in an area that's removed for epilepsy have a genetic problem? You have to look really, really hard. You have to literally walk along the DNA strands of every single cell surrounding that cortical dysplasia. That's what's eluded us for so many years, because we thought it was an all or none phenomenon. We thought it was something where you either had a mutation that affected all your cells, or it doesn't. Turns out it's not the case in the majority of times. Even in hemimegalencephaly, which is the most troublesome, I think, of all the pediatric epilepsies that we see in pediatric epilepsy surgery, about 25% of the time, we can't even see that there's mutations in the normal hemisphere. How many of you guys have heard of hemimegalencephaly? That's one of the reasons we do functional hemispherectomy. And those were some of those beautiful MRI photos that Wes showed on the slide. Those were hemimegalencephaly. But I totally derailed, so I'm going to get back on track. There are a lot of known and frankly unknown genetic causes of epilepsy, all right? We're limited again by how hard we can look, like the Invitae panel, or whatever the panel is that your neurologist sends out for, that's screening blood, okay? But like Wes was just saying, there's a lot of times that there's mutations that you won't find in the blood. You only find them in a subset of brain cells that can only be accessed at the time of neurosurgery. The most prototypical of all the genetic epilepsies are the ion channelopathies. Now, as you guys probably know, there are a lot of epilepsies caused by sodium channels, potassium channels, calcium channels. Those are the things that occur in nerve cells that allow our nerves to fire. The one that we think about the most, that many of you have heard of, is Dravet. Dravet is a sodium channelopathy. There's a lot of exciting work happening in Dravet right now, and I think, I hope, that when I'm ready to retire, we will have cured Dravet. I think we're going to get there. It's the one that we understand the most. There's some very exciting gene therapy out there that I can't talk too much about yet, but it's there, and there are going to be trials that are going to be starting probably in the next few years. Okay? But there's way more than that. And one of the things that Wes and I are both very interested in is the mTOR pathway. I'll talk about that in a second. And then there's all these other genetic problems that we don't even understand. We haven't even identified. Believe it or not, even though we can identify genetic changes in the human genome, we don't even know what all these genes do. We don't have a definition for all these genes. So sometimes we'll have, and maybe your children or your loved ones have had a variation of unknown significance. Have you guys ever heard that term before? That's where there's a genetic change that we don't even know whether it's a meaningful mutation or not. We don't know how to use that clinically yet. So the ion channels, Dravet by far and away is the most studied, perhaps the most understood, a very problematic condition that's a sodium channel mutation. And unfortunately, children don't universally survive into adulthood with it. They have terrible epilepsy. But there are a lot of others. They're listed here. Usually when it's an ion channel problem, the MRI might be stone cold normal. And so you may see an epilepsy surgeon and they may say resective or disconnective surgery is not on the table, but perhaps a VNS, vagal nerve stimulator. And now we're foraying a bit more into deep brain stimulation, responsive stimulation that Taylor talked about in the previous talk that we're happy to talk about with you guys too. Sometimes you can have an ion channel problem and still have something on your MRI. And then it gets very nuanced as to what we might want to do, because we might want to offer you or your child or your loved one a surgery to target the abnormality on the MRI, even though we know that there's mutations that affect the ion channels. Because one of the things we think a lot about is quality of life and reducing seizure burden. We'll talk about that too. Generally speaking, with the ion channelopathies, if there's a lot of different lesions all over the place on the MRI, we might guide you more towards a vagal nerve stimulator or deep brain stimulation. Okay? But perhaps the thing that we nerd out about the most right now is this enzyme called mTOR. mTOR stands for mammalian targeted rapamycin. And it exists, it's a protein, it's small. If you want to get really nerdy about it, it's 289 kilodaltons. I hope one day if I'm in the desert and I need a glass of water, someone asks me how many kilodaltons the mTOR is, and then I survive. It's the only use for that particular fact. But the mTOR, so mTOR exists in every single cell in your body. It's ubiquitous, okay? And this little guy, this little mTOR guy, it does a lot. It's involved in your cells dividing, surviving, what we call differentiating, which means deciding what kind of ultimately adult cell it's going to be after it grows up. It's really implicated in a variety of diseases: epilepsy, autism, trauma. It's for those of you who've ever seen the movie Zoolander, it's really hot right now, like Hansel. No? Okay, all right. They don't get better, by the way. It's so hot right now, mTOR. And there are a lot of well-described mutations in the pathway that we see clinically. In fact, last week, I did a hemispheric surgery on a baby who has a DEP-TOR mutation, DEPTC5, which is listed right here. That's a very well-known, well-described genetic issue that leads to hemianencephaly, where one of the hemispheres is overgrown. Hemispherectomy is the surgery you do for that. But there are a lot of others, and I'm listing them up there, and I know right now it looks like alphabet soup. PI3K, AKT, AKT3, mTOR, TSC. Does anybody know or have a loved one with tuberous sclerosis? Has anybody heard of TS? TS is the prototypical genetic disorder of mTOR. It's the one we probably understand the best, so I say we still have a lot that we need to do there. And then there are all these other genetic disorders that we're still really trying to understand. Variations of unknown significance, microdeletions in a variety of chromosomes. And the way we're learning about this is by studying resected brain tissue. Because a lot of these occur not in every cell in the body, but in a percentage of cells that surround an area that generates epilepsy, which makes it really challenging to study, but it also makes surgeons like Wes, or me, Gary, or Dave Bondo over there, really key in figuring this out, because we need access to the brain tissue to understand why. Okay. Now I'm going to back up a little bit, and I'm just going to talk about surgery. For epilepsy, it's going to be a little bit of a rehash of what Dr. Taylor Abel talked about a little bit, because the very first statement that I made, which is 100% of pediatric epilepsy surgery is genetic, means that the truth is there are a ton of options for children with genetic epilepsies. See, I think we limit ourselves when we think of genetic epilepsy as Dravet. That is a very well described genetic epilepsy, but I'll tell you that every single child with focal cortical dysplasia that any of us resect, that's a genetic issue. It's a genetic issue. It's just occurring on a different time and spatial scale than something like Dravet. Okay? But it's just as genetic. Which means that I hope that before I hang up my spurs at the end of my career, we're actually treating kids with medication to actually target these mutations as opposed to operating on them. So maybe one day I put myself out of business. I'd be okay with that. I'd be okay with that. So, stepping back, when we think about the approach to surgical epilepsy for your child or loved one with a genetic form of epilepsy, we think of them exactly the way Wes beautifully put up that slide of, is this something we think we can cure? And that's going to be an ablation or a resection or a disconnection with the goal of 0 seizures. Okay? Or do we think this is something that we can't necessarily get to 0, but we can get it better? We call that palliative. Palliative options are the corpus callosotomy, neuromodulation, which is vagus nerve stimulation, DDS, RNS, all those things. Okay? And that's the way we typically think about it. Sometimes we'll even remove or disconnect brain tissue, even though we think it's palliative, because it's that meaningful for quality of life. A great example of that would be a child I took care of a bunch of years ago from Idaho who had hemimegalencephaly, which means one hemisphere was overgrown and very problematic, but had a couple changes on their brain scan on the good side. All their seizures were coming from the bad side, and this child was under the age of 1, having 100 seizures a week. We made a conscious decision together with the family to do a hysterectomy, to disconnect the bad side, knowing that there's a chance that the good side might become a problem at some point. And fortunately, that was 3 or 4 years ago, 3 or 4 years of seizure freedom later. I still get a Christmas card from them every year. She's been able to do a whole lot more than she ever could have done if she hadn't had a hysterectomy. But it's still a palliative approach, which is a little mind-bending, that we would sometimes do a disconnective procedure, even though we think it might be palliative. And that kind of speaks to the way the plate tectonics of epilepsy surgery are shifting, because even though 0 is best, less is good. And there's a lot of great evidence out there that suggests not only is quality of life better if you're seizing less. I mean, that sounds so intuitive, right? You guys all have loved ones that have epilepsy. Surely their life would be better if they were seizing less. That's a no-brainer, no pun intended. But it turns out that less seizures also reduces the risk of dying. And that's a revelation, because we never thought of it that way before. We never thought of less seizures reducing SUDEP risk. It turns out they do. And so, even if neuromodulation or disconnection or these palliative options can't get you, your loved one, your child to seizure freedom, it can still reduce death and disability secondary to epilepsy. There's a lot of good studies out there showing that. It's very compelling. I don't think it's even something we're debating. Okay? So when you're thinking about doing a brain stimulator or vagus nerve stimulator, think about that too. Yes?
Can I also add?
Of course you can.
That the other thing that less or fewer seizures impacts is your brain development, cognitive, psychological, intellectual development.
In theory. It's not been proven.
There's a lot, I'm going to back Dave up on this. There's a lot of really compelling data to suggest that developmental velocity, how fast your child develops, is slowed down by both epilepsy and the medications to treat that.
Well, I've seen it, so I know that's true.
Yeah, absolutely. And I think that is a very compelling argument for 0 or less. Very compelling. So yeah. And I think this gets to this seizure freedom versus seizure reduction argument. And I'm going to say it again. 0 seizures is best. It's what we want for every child. It's when we think about the dichotomy of what we're going to do, when Wes or I or Garrett, Dave, when we're in an epilepsy conference and we're evaluating a case, we're aiming for the moon. We're aiming for 0. but we know sometimes we can't get there. And if we think we can't get there, we know we can't get there, less is still better. 100%. 100%. And like I said, it used to be that palliative surgery was about quality of life, and it still is, and it's really important, okay? But it's more than that. It's reducing that CDEC risk. It's accelerating neurodevelopment. There's a lot of downstream benefit to palliative surgery that may not necessarily cure. Responsive neurostimulation goes by the trade name NeuroPace. It is the only device FDA approved 18 and above. We can talk about that. That's important. 18 and above to treat epilepsy that has 2 sites of origin in the brain. That's the FDA labeling for it. Now, Taylor talked a lot about some of the other ways we use it. We are using it in other ways, but I have to be clear that those are not FDA approved, and they are what we call off-label. Now, there are a ton of things we do that are off-label in children. Believe it or not, routine medications that are given for things like asthma are actually off-label for children under the age of 1 or 2. Why the FDA has never evaluated a clinical trial, evaluating that particular application, we still do it. Okay? But it is off-label. With responsive neurostimulation, there's a computer that's placed in the skull, and then brain electrodes that are either on the surface or in the depths of the brain that read electrical activity and then respond to it. Think of it as a smart device. It's reading, detecting a seizure. We teach it to detect a seizure. Actually, you guys help. Teach it to detect a seizure, and then it responds to it. And overall, depending on the study, depending on the application, you're looking at about a 60% mean reduction in seizures with that device. And if your child is seizing every day, that could be seizing twice a week. And that's a huge difference. That's an incredible difference in the quality of life for that child. Vagus nerve stimulation has been around for a very long time, over 20 years. The mind-bending thing about vagus nerve stimulation, despite it being around for 20 years, we still don't really understand how it works. And even wilder than that, we have a really hard time predicting how well someone will respond to it without just implanting it. There's no test that we have at hand that can say, okay, Wes, we're going to do a VNS on you based on your seizure type and frequency. It's going to work 40% of the time. It's going to have 40% reduction. We have no test that tells us that. So generally what we tell people is we try it, we give it a year, and we expect about a 50% reduction in about 50% of children with VNS. What that means is if I implant it in 100 children get VNS, and we ask them to line up, 1 to 100, we ask them to line up in order of how well it worked. So the first child in line didn't really have much of an effect. The 100th child in line had a 100% reduction in seizure-free. The 50th child in line has about a 50% reduction in their seizures. Okay, does that make sense? It's a convoluted way of thinking about it. That's the data. Deep brain stimulation is where we also implant a pacemaker, but there's electrodes that go in the depths of the brain. The thalamus right now is what everyone's talking about, but thalamic neurostimulation has been around for over 30 years. We're just starting to explore it again in children. That's a whole conversation of itself. Central median thalamic neurostimulation, we've been doing in children now for about 8 years, 9 years, I'd say. It's off-label. It works pretty well. Most of us who are doing it for a while are seeing about a 50 to 60% mean reduction in all seizure types. This includes kids with generalized epilepsy, Lennox-Gastaut, all types of applications. Anterior nucleus downward stimulation has been around for about 15, 16 years, more than that actually. The trial that was published describing it is actually now about 13, 14 years old. And that's used for people who have temporal lobe epilepsy. And the newest thing is something called pulmonary neurostimulation, which is what we're exploring now.
Dr. Hauptman?
Yes.
Could you explain why the thalamus, what's important about the thalamus?
Thank you so much. Thank you, Mark. Thank you. The thalamus is the motherboard. The motherboard of the ship's computer. Okay? The way it works is that all information from the surface of the brain gets channeled to the motherboard. The thalamus is in the center. So the idea is that instead of having to cover a large swath of the brain with a neurostimulator, what if you put it in the bottleneck? What if you put it in a small area where all information seems to funnel? That's thalamus. And so the way I imagine that neurostimulation works in the thalamus is, imagine the neurostimulator is a little guy with a ping pong paddle, and the seizures are ping pong balls, and they're being shot all the time, and so this is what the neurostimulator is doing with thalamus. It's doing it all day, every day. Now, it depends on whether you have a neuropace, which reads and responds to the data, or whether you have what I call the set it and forget it, the Ronco Peel. No? Ronco? Thank you. Thank you for Ronco Peel, set it and forget it, rotisserie chicken. Am I really that much older than everybody in the room? Don't even do that to me, guys. I mean, my knee does hurt. But, my knee does hurt, so, which is why I live in Phoenix now. So, the way that works is that it's constantly stimulating the thalamus. And it seems to be doing it with minimal to no side effect, other than reducing seizure burden. So I've actually become quite fond of deep brain stimulation, done quite a bit of it over the years, and we can talk about that too. And then we'll end on this slide, which is, again, my hope is that at the end of my career, we're going to be treating kids medically. And the way we're going to do it is by identifying, let's just identify those mutations for us. And then we're going to have clinical trials in which we repurpose drugs that already exist, many of them in the cancer world. Already these drugs are working on those genetic pathways. We just need to figure out which pathways need to be targeted. A couple of years ago, I started a clinical trial in Seattle when I was there in Seattle for the majority of my academic career, in which we used a repurposed cancer agent that blocks the mTOR pathway. And we took a bunch of kids who failed epilepsy surgery, and we put them on this drug. And we found that in some of these children who had no mutations in that mTOR pathway, they completely stopped seizing. Now, that is very early data, and it's like any of those things, like the weight loss commercials, results not typical. Okay? But it does give us hope, and it gives us optimism that we're onto something here. And I think that while Wes and I are speaking at 2 o'clock on a Monday afternoon, 10 years from now, Wes is going to be headlining this place because it's going to all be genetics. Because I think ultimately, every single surgical epilepsy, I'm not everyone will agree with me when I say this, I'm going to say it anyway. Every single surgical epilepsy has a genetic origin. And until we figure that out, we're going to be doing surgery because it works really well. So I'm not saying we shouldn't be doing surgery, but I'm saying that if 20 years from now when I'm done with neurosurgery, if we're still doing it this way, I'm going to feel terribly disappointed. And I don't think we will be. I'm super optimistic about it. And I'll stop there. So, thank you.
We have a few minutes for questions, if anybody has some. Dr. Maynard, you're cheating, but we'll let you. He's their boss.
I'm just going to make one of those statements that I have to maybe back up later. I'm going to say something controversial. It is my feeling, now retired from this, is that I think we should be doing next-gen sequencing on every piece of tissue that is removed from patients for epilepsy surgery, no matter what. But you can't get insurance companies to do that. But that's, to me, if you want to go forward, we should be sequencing everything.
I agree. My lab does.
And I'd say that there are some workarounds. So you can do PCR panels
Then 500 deaf.
Yeah, they are.
I'm thinking 500 deaf.
They are. They're
For now.
Yes,
For now.
yeah. No, they are limited. But I think that's going to be the first step in that direction. Because, you know, unless you're at a place where this is a research endeavor, it's not going to stay with care. That's the issue. But I agree that we should have something in there.
So that's what I was wondering. My son does have genetics at D1B, but he's also going to be doing the RNS in the thalamus. But while doing that, they wouldn't be able to take something out and test. Is that what?
It's not a, yeah, so, I'm certainly going to list it too. We don't routinely biopsy brain tissue at the time of the RNS implant. Even if you would, the thalamus is probably not the place where I would do it. Because that area is super tightly packed with important brain cells. And so you kind of don't want to cause an issue there by doing a biopsy. So I'd say be a little limited.
Yeah, I agree. I think that, you know, we're not ready for prime time as far as making those genetic discoveries in brain tissue that we would have sort of a treatment that would be worth the risk of doing a biopsy on those tissues. So while for things like RNS or DBS, we really don't have the option to test brain tissue, there are other techniques that are emerging for things like stereo EEG, for instance, for patients that have stereo EEG, where we're able to get brain tissue from those electrodes in a way that doesn't cause any additional risk. And so I think moving forward, you know, we're working on ways, even through like maybe cerebrospinal fluid or other minimally invasive ways, so that we have access to brain-specific or brain-limited mutations without taking out brain to do so.
I realize there are a lot of different variables depending on the patient that go into the decision, but as a mom whose kid has been medication resistant, she's been on 3, 4, 5 different types of different combinations of medication and she's still resistant. Surgery, for one, has not been put on the table for us. But for two, my question is, as a concerned parent, would you recommend starting with something minimally invasive such as VNS and tiptoeing into the electrothalamus and then tiptoeing into a brain resection and having that tested? What are your recommendations based on that in the most general scenario that you can imagine?
It all depends on the region or the regions of the brain that are affected. And so it's very case specific. So if there's a patient that has a focal lesion and a sort of diagnostic workup, some of the things that we were talking about that lead to that place, I recommend going straight in and doing surgery, for instance. Whereas for patients that have a little bit more uncertainty of where those seizures are coming from, then more tests, including invasive intracranial monitoring, may be the next step. Now, it depends on the other sort of studies about, you know, is this a focal epilepsy? Is it generalized? So those all sort of dictate what the next steps will be in the workup.
Yeah, but let me say, like, you know, even though things are case specific, we have a general rubric that we use for everyone. So, first thing I would say is that 100% of children with intractable epilepsy can get VNS. There is literally one or two soft contraindications to VNS. Like sleep apnea, sometimes if you're on the verge of swallowing issues, we have a discussion about that. Other than that, every single child gets VNS. So that's something certainly worth talking to your epileptologist about. Our rubric, generally speaking, is actually really straightforward. I mean, you can draw it on. The first question is your child medically intractable? Yes, we have a very specific definition for that. It's 2 medications appropriately dosed and tolerated, yes or no, right? And actually, It's only one medicine if your brain MRI is positive. That's probably been one of the last ones. So once you're intractable, then really the question is, just like what Westley was saying, once we get all the data, we look at the MRI, we look at the EEG, we look at neuropsychological evaluation, things like that. If there is a spot in the brain that is safe, that's key, safe to do something about, like remove. If we can identify that spot, if it's an area that's safe, that won't change your child the way that you don't like, the way that won't give us more heartburn than you already have, then you offer your curative surgery. But if we're on the fence about it, then we have a conversation about, like you said, but I think to answer your question, the most important thing is get all that data. Go to your epilepsy surgery evaluation center, whatever close to your residence. There's a lot of great places around. Get all that data so you have those options. Because it really is a palette of options you have to choose from. And there are plenty of times where maybe a child is candidate for brain surgery, but you're not ready for that. That's okay. We're here. We're not going anywhere. Hopefully. And so if that's the case, then you do whatever the goals are for your child, that's what we need to guide you in that direction.
One more question up front, and I think this will be the last question.
There's nothing after this.
Oh, okay, so after you, if you want to
The
stay.
rest can never go.
Is it easier to identify the genetic issue if siblings have similar epilepsy? For instance, I have two boys that were diagnosed about the same time and progressed similarly. I mean, they're 9 years apart, but judging by the way things are going, it's pretty similar progression.
Yeah, so I would say it doesn't necessarily make finding the diagnosis easier, but it certainly gives us what we call a positive predictive value, meaning what our likelihood of finding something on those tests would be. And it certainly would encourage someone to do those tests when we see that multiple siblings or a parent and their child have epilepsy. That suggests that there is a clear link to inherited, genetic alterations that are contributing to epilepsy. And so in those cases, and I think that we should be doing it for all cases, but if we're not doing it for all cases, those cases especially we should be doing it.
It's something what my kids today call sus.
Now you're not aging yourself,
Thank you.
but you're embarrassing
I
yourself.
didn't say that. Here's what I'm going to tell you guys is, when you're thinking about what Wes and I are talking about, you have to forgive the field of medicine. Because in 100 years, things have changed actually quite rapidly. 100 years ago, an old doctor would get a disease named after them because all they simply did was describe the physical manifestations of that disease. Neurofibromatosis, if those of you have heard about it before we knew anything about the genetics of it, was named after a guy named Barrows, because all he did was describe the physical attributes of that disease. Then, 40 or 50 years later, we had a microscope. We had slides, and dyes, and tissues. And now, we weren't just describing the physical manifestations of the disease, but also what it looked like under the microscope. 50 years later, we're at a deeper level. We're looking at things on a single cell genetic level. 100 years ago, it wasn't even possible. So I guess what I'm telling you is that we're still catching up. Only 100 years ago, not that long ago, we were just talking about the way something looks by looking at it. 100 years later, Wes can detect 5% of the nerve cells around the brain regions having a genetic alteration. That is a huge, huge shift. But the rest of the field needs to catch up because we're on the bleeding edge of next 15 to 20 years, we're going to be beyond it. We're probably not even going to be using tissue anymore. We're going to be using artificial intelligence and looking at the brain MRI and using some key questions that we have not figure out with the genetic alteration. We're headed. It's going to be faster because it keeps getting faster. Okay.
Any other questions?
I can't really read, so I apologize, but how is the epilepsy surgery considered non-invasive?
How is it considered?
How is it considered minimally invasive?
Yeah. Yeah. That's
Sorry, I just came in late.
Yeah, no, that's a great question, and I think we could say less invasive because we're still going into the brain. When we look at sort of the arc of epilepsy surgery, when we think about the surgeries that were commonly done, by Dr. Mathern and that sort of generation of epilepsy surgeons, we're talking about big surgeries with big incisions, with big pieces of skull taken out, and large pieces of brain being resected, which we still do. But when we talk about minimally invasive surgery, we're talking about things that require very small incisions that are, the size of your pinky nail, with very small, holes in the skull. And so when we talk about minimally invasive, it's relative. It's still invasive. It's like a less invasive surgery, but without knowing sort of the history of what was done or what we do for some cases, then it would be, like I could show you some pictures, and if you saw option 1 and 2, you would probably agree that one was at least less invasive.
The funny thing about minimally invasive is that the terminology really comes from other surgical specialties, particularly general surgery, where there was a time where if you needed your gallbladder out, we were getting an incision this big, you're going and you're reaching into their hands with big old paws and then pulling them out, and then they were in the hospital for a week and all that. And so minimally invasive traditionally means smaller incision. But here's the trick, is that in brain surgery, smaller incision actually doesn't necessarily translate to faster recovery because the brain itself doesn't process pain. Think about that one. So if you're in surgery and you're looking at the brain, I would never do this. But if you were awake and looking at the brain, no one would feel it. No one would feel it. And so we adopt the phraseology minimally invasive. That means small incision in the nurse. That's the sort of, I didn't want to wait here before. I can't help it, so talking, I can't help it.
Anybody else?
Yeah, sleep apnea is a soft contraindication for VNS. Now, I caveat that by saying the newest iteration of the ignorance stimulator, this is really that new, has a way to modify stimulating daytime and nighttime, as well as scintillating along with that. That overcomes a traditional limitation of VNS because there was some thought that at night, when it's stimulating, it can worsen sleep apnea. Does he have the old model of VNS? I'd be worth chatting with your neurologist about it, because you might want to, if it's the new version, 1000, you might be able to program it differently at night if that's the reason. Or he can swap out, because it's probably due for a battery change pretty soon. Yeah, I wonder if they upgraded him to the 1000. But if they did, then that means he can change the program. Sorry.
No.
Thank you. Thank you for your research.
My daughter has suspected tuberous sclerosis, and we actually,
We actually recently just had surgery by the great Dr. Hauptman, and she's been negative on every genetic cheek swab test that we've had. And I'm just curious, if we did choose to do like a sequencing or something on the brain tissue, would that be more just informative, or would that actually be helpful to the course of her therapy?
Yeah. No, that's a great question. I think now, as I sort of mentioned earlier, sort of the genetics that we are seeing from the brain tissue is informative for future therapies, but it doesn't necessarily inform what your daughter would have as far as their treatment.
But it is something we talk about. It is something we talk about, because we can send it now.
Okay.
I'll check with you.
Okay, awesome, thank you.
Right. Okay, thank you guys so much.